All right, well, good afternoon, everyone, and welcome to today's webinar on aligning for social and health needs in the community. During the webinar, you'll hear from leaders from 3 hospitals and health systems about their work to improve individual and community health outcomes by better aligning social and health needs. My name is Melissa Quick, and I am a co-chair of Aligning for Health, an advocacy organization focused on addressing the barriers and challenges that limit our ability to improve health outcomes and well-being for all. We are excited to co-host this webinar with one of our members, the American Hospital Association. Shira Hollander, the Senior Associate Director of Policy Development at the AHA, is joining me today as a co-host and will moderate the discussion. But before we start, I wanted to take a quick minute to provide a little bit of background on social determinants. At Aligning for Health, we believe that social determinants factor into our overall health and well-being, and that healthcare itself is only one piece of the equation. Lack of adequate housing and nutrition, socioeconomic status, and race all contribute to our health. Unfortunately, as we have seen, the current COVID-19 pandemic has provided a real-time example of just how social factors can lead to disparate health outcomes and disproportionately impact communities. As a coalition, we are focused on developing and promoting actionable policies to address such challenges and to create opportunities for states and local governments, healthcare organizations, and non-healthcare organizations to work together to develop cross-sector coordinated solutions to address health and social needs. Overcoming these challenges is difficult, but many organizations are making progress. Hospitals and health systems across the country are taking steps to address social and health needs through screening, connecting patients to community resources, implementing hospital-wide initiatives, and engaging, partnering, and/or investing in their communities. So for today's webinar, we are excited to highlight the work of several leaders of hospitals and health systems that are working above and beyond to create partnerships, transform care delivery, address bias, and to advance innovative and effective practices, all with the goal of improving individual and community health and achieving health equity. So first, we'll hear from Dr. Kimberlydawn Wisdom of the Henry Ford Health System, followed by Irene Kaufmann of Bronx Partners for Healthy Communities and St. Barnabas Hospital Health System, and finally from Susan Fuehrer of the Institute for Hope within the MetroHealth system. We aim to leave time after the presentations for discussion and questions. Please type in any questions that you have for the panelists into the Q&A box, and we'll go through as many as time allows. So first up is Dr. Kimberlydawn Wisdom. Dr. Wisdom is the Senior Vice President for Community Health and Equity and the Chief Wellness and Diversity Officer at the Henry Ford Health System. Dr. Wisdom has been a board-certified emergency medicine physician for 30 years and chair of the Gail and Lois Gordon Endowment on Multicultural Health. She focuses on healthcare equity, infant mortality and maternal and child health, chronic disease, physical inactivity, unhealthy eating habits, and tobacco use. Dr. Wisdom provides strong leadership in diversity, population health, and improvement of the health of those disproportionately impacted by poor health outcomes. And with that, I turn it to Dr. Wisdom.
Great. Thank you, Melissa, for that kind introduction. Can you hear me well? Great. All right. I'm really pleased to be here. Thank you, Aligning for Health, as well as the American Hospital Association. And I'm delighted to be joined by the other panelists as well, and looking forward to a lively discussion. So I'm going to go ahead and move through my slides and kind of give a perspective in terms of, what we're doing at Henry Ford Health System in the Detroit metropolitan area. Next slide. Great. So just Henry Ford Health System very quickly is a large vertically integrated health system with 6 hospitals, many ambulatory care sites spread across our 4 counties. We have a medical group of about 1,200 physicians, and we have a private practice group that works very closely with us as well. A health alliance plan, which is our insurance health plan. We have a large academic mission. We have about $100 million in grant funding per year. So a lot of bench research as well as health services research, and then retail lines as well. Next slide. So I'm just going to share very briefly that we're going to be talking about social needs and aligning those. And many of you are familiar with the social determinants of health, or those conditions that lead to health and well-being. And some of them are fairly complex and upstream. Some of them are really addressing social need. So advance to the next slide. Much of the work that we have been currently involved in, I'd say the majority of our work is one that addresses social need. So if you look at this diagram, this kind of outlines, this is a great article out of Health Affairs that came out last year, but just to differentiate social needs versus social risk versus social determinants. And while I'm not going to go into a lot of detail, I would say much of our work falls in those bottom two tiers, really addressing social need around food, housing. Of course, that has been accelerated in the advent of COVID. However, we do look to move further upstream in terms of addressing social determinants related to creating permanent affordable housing and food sources, not just the distribution of food, but actually providing the ability for people to shop in different venues. So, and walkable communities and that sort of thing. So that's moving further upstream, and of course working very closely with our many other partners. But much of the focus right now in terms of addressing social need are falling within that social risk and social need category. Next slide. So just, I'm going to give a little bit more of a focus in terms of the COVID context. And we know that health and healthcare disparities have existed. They've existed for a long time. There have been a lot of research that's been done, unequal treatment, a lot of landmark publications that came out in about 2002 that showed that certainly health disparities were persistent, profound, and they really tie into the social needs and social determinants very well. So just as an example, in the state of Michigan, only 14% of our population are African American, yet 30% of the cases of COVID were, 30% of the people were African American, and 40% of the deaths were represented by African Americans. So certainly that disproportionate impact on communities of color, brown and Black communities. Next slide. So actually early on in our work, we often talked about quality and equity were two sides of the same coin. This was back in 2008 when we were really trying to move on that equity journey. And I'll describe that a little bit more in a subsequent slide, how important the nomenclature is. But we linked equity to the quality proposition. And I'm saying at this point, even now, social determinants of health or social needs are key to eliminating health and healthcare disparities and moving toward achieving health and healthcare equity. So we might even, consider determinants and equity are actually two sides of the same coin now. Both inextricably linked and very important. And you can advance to the next slide, actually the slide after that, because I want to make sure I keep this moving so we provide plenty of time for Q&A and hearing from our audience. So health disparities and achieving that health and healthcare equity. I'm just going to outline just a few key domains that we have focused on that the other speakers as well can speak very eloquently about. So I'm going to walk through a few of those now and the importance of having these in terms of addressing social needs, social risks, social determinants, and closing health and healthcare equity gaps. Next slide. So I'm going to touch a base on how important data is, very high level nomenclature in terms of understanding what we mean when we talk about equity, how to have programming shovel ready, which we had to be in order to be responsive to the COVID. Also addressing social needs, some of the specific examples of what we're doing there, how important training and education is ongoing in the space, and how key partnerships are. And we want to achieve the triple aim, better care, better health, lower costs. And some people, that fourth aim or that part of that quadruple aim, people have different elements of what that is. Sometimes it's readiness, sometimes people have other iterations of what that fourth aim is, and oftentimes we say that fourth aim is equity. Next slide. So in terms of the data and the ability to collect data, so we started collecting the race, ethnicity, and language. That's not a typo, that's A is small. The real data collection started quite, probably 2009, 2010, and we also asked at Henry Ford, we asked for ethnicity as well, so we can know well the population that we're serving, and then we're actually able to stratify our data to see how effective we are in various programs that we're conducting. So we actually have had a whole campaign called We Ask Because We Care. We borrowed that from Robert Wood Johnson Foundation and George Washington University, and any of you are very willing to borrow it. You know, you're welcome to borrow it from us. Just take it, share it. It is not proprietary in any way, but we needed to ensure that we could stratify that data, ask the data through self-report, stratify it so that we could better serve the populations in our communities. Next slide. So in terms of nomenclature, I touched on equity earlier, and I may be preaching to the choir a little bit here. People say I clearly understand that, but please borrow this slide and know that you can share this with your communities. In terms of, many people use the word equity and equality synonymously, and just the clarity that we're trying to achieve equity, and that means that we want the inputs necessary so that each of our community members, health system members that we serve can maximize the best outcome. And as you see, equality, if you provide equality, that's not sufficient, because you'll see that smaller child on the far left is not able to see the game at all. But what we're looking for is equity. Ultimately, everyone can realize the most favorable outcomes, and ultimately, we want to see liberation, where we remove as many barriers as possible so people then can actually realize the best health outcomes and the best outcomes for their lives in terms of their health and well-being. Next slide. So in terms of programming, and being shovel ready, in Detroit, we have one of the highest infant mortality rates, or infants dying before their first birthday. So we've made very deliberate and intentional efforts to close those health disparities gaps. And so we developed an effort with funding from multiple excellent funders, our Robert Wood Johnson Foundation, Kellogg, Kresge, and many others, to develop a effort called the Women Inspired Neighborhood Network, or WIN Network Detroit, where we identify pregnant moms that are at risk, women of color, and link them. They come in for actually group visits for their prenatal care. And those groups visits, they last for 2 hours, are co-facilitated by a community health worker and a certified nurse midwife. And that community health worker then goes and visits each woman to help her address her social needs in a very comprehensive way in between her clinic visits. And we've had well over 550 births now. Of course, these women are delivering all the time. And we've had one preventable infant death. And that infant death actually occurred due to a sleep, co-sleeping. But we've had women that are very high risk of having preterm birth, low birth weight babies, and they've had very successful deliveries, full-term babies, and initiating breastfeeding. So we've seen some very favorable things happen. And even with COVID, we were shovel ready enough that we began to actually deliver food and information to these women in their homes. And now, just as of last week, we're fully approved to now do virtual visits for group prenatal care. Also, I just want to mention, it's called Women Inspired Neighborhood Network Detroit, but there's also Women Inspired Neighborhood Network Cleveland, because they wanted to replicate the model in Cleveland, and we gave them everything, including the wireframe of the website, to them so that they could replicate the program there. And others of you across the country are welcome to do the same. Please reach out to us. This is not meant to be solely focused in Detroit or one community. We designed it very specifically with the globe in mind. And so we wanted to spread and scale. Just very quickly, another initiative is our Fresh Prescription Program, where we actually have providers writing prescriptions to help people gain access to fresh fruits and vegetables. We give them a voucher, we give them a coach to help coach them, and we've actually had people, their hemoglobin A1Cs drop significantly based on the statistically significantly drop in their hemoglobin A1C values. So we're pretty pleased with this effort as well. Next slide. And housing, go ahead, move to the next slide. As meeting social need, during COVID, we were able to work with a organization called NSO right there in the middle, Neighborhood Service Organization, that primarily meets the needs of the homeless. But because we collaborated with them during the COVID experience, we were able to develop a whole recuperative housing project pilot, and we received about $300,000 to actually house people who are housing insecure and help put them into more permanent housing, especially during the time when the COVID peaked, and we're continuing that, and actually trends that is being now we're looking to sustain it long after the funding. And during Q&A, I can answer more specific questions if people have those, but it's been pretty exciting. And in about 1 minute, I'm going to conclude, but just training and education has been really key. We've actually accelerated our unconscious bias work. We're working with our senior leaders. We're working with various clinical teams, particularly the women's health team, to develop curricula in order to advance unconscious bias training, but also we want people to build skills around unconscious bias. So we don't want a checkbox one-off type of experience, but how then can we advance that even beyond the training? And my next to last slide is about how key partnerships are, and that without, whether it's our faith-based network or our, we have over 200 community partners, without them, we would not have achieved some of the favorable outcomes we've achieved in our community, because they've been invaluable. So we have connected with them even as we're getting ready to do more COVID testing, and now flu vaccine administration, which will start in the next couple of weeks. Our partners are just invaluable. We work with probably at least 40 schools. We work with 40 health faith-based organizations and many other senior centers and that sort of thing, to ensure that we're able to get our messaging out, but also deliver the services in the community that we desire. So I think on that note, I'm going to turn it over to the next speaker.
Great, thank you so much, Dr. Wisdom. All right, so next we have Irene Kaufmann, who is the Senior Vice President at St. Barnabas Hospital Health System for Population Health and the Executive Director of Bronx Partners for Healthy Communities, an emerging performing provider system created to implement and manage DSRIP, the New York State Medicaid Redesign Program. As Executive Director of BPHC, she is responsible for integrating services delivered by a coalition of more than 200 provider organizations and community agencies, implementing best practice programs and working with clinical leadership to focus care delivery on value, reduce avoidable utilization, and use payment incentives to drive improved outcomes for a population of 375,000 individuals in the Bronx. Irene?
Thank you. Thank you for that introduction. So good afternoon, everybody. It's really a pleasure and a privilege to participate on this panel and to address this audience. So I've had the opportunity and privilege of leading the Bronx Partners for Healthy Communities. We're one of 25 performing provider systems covering the regions of New York State who have worked since 2015 to improve care by reducing avoidable readmissions, improving population level outcomes by focusing on value rather than volume, and transitioning to preventive care with a focus on activity that takes place in the community as opposed to institutional settings. At SBH, where we've lived this program every day, it has become clear that collaboration, coordination of care, and the sharing of data, technology, and communication with other providers and community organizations was central to accomplishing our mission. It has also become very clear that in order to achieve these transformational changes, we needed to engage in and improve how we address social determinants underlying the chronic conditions that affect the populations and the communities that we serve. Slide, please. And you can see some of those social determinants that we're addressing in the Bronx on the right side. The Bronx has for years presented some of the worst health indicators in New York State. We're 62 out of 62 counties in New York State. The Bronx has likewise historically held some of the worst economic, social, employment, and education indicators in the state, and unfortunately the country as well. So health and social indicators are inextricably linked. There's not one provider or organization that can on their own successfully change that portrait. And at SBH, we've had to integrate teams and effort with our community partners in order to have any success in remediating community health. So today I wanted to share with you some of the work that we've conducted before, during the COVID surge, and now moving forward into the fall that has taken this integrated approach, and an approach that continues to lead us to transform how we provide care. Next slide, please. So first, addressing access barriers with technology. In the Bronx, transportation is really spotty and unreliable. Patients with clinic appointments often choose between coming for care or missing a day of work. We had considered telehealth to alleviate some of this burden, but could never really get it off the ground. During the pandemic, the implementation of telehealth was an eye-opener for us. First, New York State issued executive orders, and the Office of Mental Health issued waivers that finally allowed providers to bill for telehealth visits. These are telephonic visits. By the first week of March, we were already beginning to replace in-person visits with televisits, as you can see here. Remarkably, in mental health, we were able to develop protocol, workflow, and implementation within 4 to 5 days. And within that time, all patients except those who were on IM medication were scheduled for telephonic encounters. We have been able successfully to sustain that conversion to virtual visits ever since. Medicine took slightly longer. I guess they had more departments, more clinical departments to engage and train, but really by May, we were already seeing more than half of our patients telephonically. The show rate has skyrocketed, with behavioral health having the highest, followed by medical and specialty services. Overall, using telehealth has made it possible to continue providing services to our patients who were sheltering home and had lost access to the limited public transportation they previously had. And our lesson here is one that focuses on using organizational alignment and purpose of goal, as well as support from both government and payers to allow payment for telehealth services. This combination of organizational alignment as well as support from payers really was critical, and it's something that we need to remember. So next slide, please. For the next two programs that I want to talk about in a more granular way, really focus and highlight collaboration strategies with multiple CBOs. The first one here addresses management of asthma. Again, in the Bronx, 1 in 4 children have asthma. That's triple the national rate. Bronx has the highest rate of asthma-linked ED visits and discharges in the city. Of the many interventions that we've implemented to improve asthma management and self-management, we felt that PCP referrals for home visits conducted by community health workers who would provide asthma education in the home, provide hypoallergenic linens, and make referrals for integrated pest management would help engage and educate all household members present and obviously reduce the patient's symptoms and severity of illness. That focus is represented at the bottom of the slide. We found, however, that only 1/3 of the referred families allowed the visit to occur. 2/3, and this actually what it meant to us is that 2/3 of the considerable outreach and follow-up resources we invested never produced that intended visit. Next slide, please. So we ultimately developed a data-driven integrated partner strategy. We work with the Bronx Rio, and this is our partner organization that manages a regional clinical data repository to identify buildings or building sites where residents had a high occurrence of asthma-related ED encounters and admissions. So this approach led us to a defined population rather than individual scattered patients. We partnered with CBOs that were already working on site, organizing and teaching tenants to improve conditions in those identified buildings. And these embedded CBOs, who had already established relationships with building tenants, made an excellent conduit for connecting the community health workers who were doing asthma education for tenants. So now, community health workers provided their initial asthma education sessions to the building rather than an individual patient. And this created an opportunity to have the tenant ask for the home visit themselves rather than to be referred from the hospital for a home visit. And this approach turned out to be much more effective because the tenant had already met the person who would do the home visit. And our lesson here was that an integrated and aligned community-based approach using data to identify a population of focus can more effectively engage clients who are difficult to engage and address very complex social determinants. Next slide, please. That integrated approach is one that we also use to address food insecurity. Again, in the Bronx, food insecurity is ranked by patients, by our community, by community-based organizations as one of the most pressing issues. 31% of residents in the Bronx are food insecure, and 1 in 3 children in the Bronx live in food insecure households. To break the cycle of food insecurity, we've worked on several fronts. To begin with, we've provided physician and resident education on social determinants and food insecurity. We've embedded screening tools in our EMR. We've developed strong partnerships for food distribution with farmer markets and food as medicine programs, as Dr. Wisdom also had described previously. And we've activated patients to become empowered consumers of produce in their own neighborhood markets. We designed tours and engaged them in conversations with the managers of those markets so they could ask for what they needed. So this is the pathway of integrated clinical and community service we have developed to address food insecurity. Again, our community partners play a critical role in the pathway, both for providing services and sharing information. We've used an electronic community resource directory to push out current information about food pantries, food distribution centers, and farmer markets. This became a most important tool for our community providers and community organizations and their clients during COVID, not surprisingly. But our deep concern were with the community residents during that time who were homebound and reluctant to leave their homes to seek services and find food. We joined the coalition aligned with Jose Andres and the World Kitchen. The coalition is called the COVID-19 Rapid Response Coalition. They had food to distribute, and they joined with us because they knew that through our community network, we could identify hotspots of hunger. From April through the end of the summer, the coalition has dropped off 1,000 packaged meals every day to community locations our community network has identified. Next slide, please. So I wanted to share finally with you one of our biggest projects, and this one is focused on integrating fitness and nutrition as a way of changing the way, transforming the way we think about care. So this is a new building that is almost ready to open. It's a 60,000 square foot state-of-the-art facility offering, and this is important, offering an integrated approach to our community's most pressing needs. The facility offers access to affordable housing, clinical care, a comprehensive gym, exercise studios, fitness and nutrition coaching, a community space, and a state-of-the-art teaching kitchen supplied by a rooftop farm, which you see right here. We invited commercial vendors, housing providers, and not-for-profits to work together in this integrated space. The focus of the center is on health and wellness, not on sick care. We believe that we can only be successful in a value-based environment if our communities have access to wellness care and coaching that would assist them to maximize the benefits of these service resources. Next slide, please. Our mission is not only to engage in value-based care, but to demonstrate to our payers that it benefits them to cover membership costs and invest in wellness care for their Medicaid members. They do this for their commercial members, but this would be for Medicaid members. Their investment will ultimately help the population stay healthier, lower excessive utilization, and lower the cost of care. Currently, with a grant from the Mother Cabrini Foundation, we are enrolling referred patients into our health and wellness program, and we will be monitoring their progress and sharing metrics and outcomes with our health plans so that we can evaluate the program's ROI. We feel certain that we can make a big impact and engage our health plans in really supporting these programs because we think that our ROI will demonstrate the benefit. Thank you.
Right, thank you, Irene. And now to our final panelist. But before I read out her bio, I would just like to remind folks, if you have questions, please enter them into the Q&A box. We also already have a good number of really excellent questions in there that we look forward to getting to. But if you have any burning questions, input it in the Q&A and we'll get to it after the final speaker. So without further ado, Susan Fuehrer is the president for the Institute for Health Opportunity Partnership and Empowerment, or the Institute for Hope, within the MetroHealth system. In this role, she aims to address social determinants of health in an ambitious, comprehensive, and coordinated manner, ideally repairing the root causes affecting the overall well-being of people in the community so that everyone can live their healthier lives. Prior to this position, Susan served as the CEO and the director of the VA Northeast Ohio Healthcare System. She spent 34 years at the VA and rose from a management intern to the CEO. Susan?
Thank you very much. Next slide, please. I know we're a little long and it's a hard act to follow, both Kimberlydawn and Irene, but I'll do my very best. And I'm here to talk just a little bit about the journey that we are undergoing and going through at MetroHealth in our work to address the social determinants of health. Next slide, please. MetroHealth is located in Cleveland, Ohio, on the near west side, and the largest Latinx patient population in the state of Ohio. It is the largest public essential health system in the state of Ohio with a history of 183 years. You can read our patients, but what's most important to talk about is 75% of all 300,000 of our patients are at risk for value-based care contracts. We've had a very successful population health initiative, and our facility is committed to moving that on forward. And this is just a picture of our new $1 billion hospital that will be completed in a couple years. We are doing economic transformation on the entire Near East Side. We will have an economic opportunity center. We are building affordable housing for our residents, both our medical residents, as well as the residents who live in the community. Next slide, please. And this work is so important that it's actually one of the 5th pillars of our strategic plan, where we are committed through our 183-year history to be a community convener and promoter of social determinants, recognizing that we really need to move upstream beyond the walls of our hospital. Next slide. And that is why a year ago, I was compelled to leave the VA healthcare system that I love to come to the private sector and work as the president for the Institute for Hope, where, as Melissa said, HOPE stands for Improving Health Through Opportunities, Partnerships, and Empowerment. And both Kimberlydawn and Irene did a great job talking about the importance of all of these components in each of our individual healthcare systems. Next slide. At the Institute for Hope, we have 3 main areas of focus. The first is the work that Irene and Kimberlydawn talked about, building those healthy families and thriving communities. You know, we are screening and we are doing many interventions to do good for our patients and the wider community at large. We also really want to develop an organizational community culture where people are equipped, and this was done long before COVID and long before some of the issues we have in our country right now, where we can really talk about equity and some of the social issues that are very foundational in this community that need change. And then the last thing that we really want to focus in on is really advancing those innovative practices. So we want to try things. We want to see if they work. If they work, we want to scale them. We want to talk about them. And we also recognize that, you know, failure, there's a lot to be learned in things that don't work. And so what we hope to do through these initiatives is to influence our partnerships through operational integration, research, publication, policy change, and financial support. Underscore both of those. Next slide, please. So we have been screening through EPIC with a few of our extra questions that we're asking across these 10 domains. They're probably no different than anybody else that's been screening them. So our goal is to get to 300,000, every single one of our patients. We, next slide, are on our way at a whopping 20,000. So we've got a ways to go, but we are screening through MyChart. We have our social care coordinators that are screening some of our most vulnerable patients, our Medicaid, Medicare patient populations through what we call our Red Carpet program. And we are, just before COVID, started face-to-face in the clinics. That's been put on hold a little bit, but now we're re-engaging so that we can screen people right in the clinic. And as you can see, MetroHealth has a broad range for a public hospital in Northeast Ohio. Next slide. So these are the results. So this is the results what we're seeing, and social connection is the highest social determinant. And many of these results were collected before COVID. And we've done several programs to address social connection. Actually, one came from our foundation board, where many of the bank presidents said, we had so many volunteers out in the community doing great things when COVID hit. What can we do? So we set up something called Calls for Hope, where our volunteers are able to engage by calling people that have been identified for severe isolation during this time of severe isolation. Irene and Kimberlydawn did a great job talking about food insecurity. Obviously, there's a lot of initiatives going on. One that I'll just talk about briefly is we have a Mas Vida program for our Latinx patient population, where we've hired professional chefs. They go to faith-based communities. They bring their most unhealthy but delicious recipe, and then the chef works with them to redesign that recipe so it's a little bit more healthier for them. And that has been a great success. Next slide, please. So this is just how we're now able to start slicing and dicing the data, and we've been really excited to get to the power as we work with our researchers and our sociologists. And this is just one way that we could slice the data, but we can actually now start looking by each domain, by our outpatient clinics, by gender, by race, by ethnicity. What are the issues? You know, where do we think we've done a great job, but we're not doing a great job? And we learned as a community in Cleveland, there's a little town called Parma, it's a city. If you ever knew Drew Carey, that show, he was from Parma. There's a high Polish population there, but we learned in the city of Cleveland, Parma has one of the highest rates for food insecurity. So it's predominantly white, it's predominantly older. You know, we were thinking Buckeye, where our African-American population is. We were thinking Huff, where the Huff riots were in the 60s. But really what we found through digging through data was that Parma had some significant issues. So now we're able to target and tailor our initiatives to that area. Next slide. And so, you know, one of the things we've been doing as we've been working to screen is it's great to screen patients, but if you don't have a way to help them, it creates quite a conundrum for the direct care providers. And so we at MetroHealth have committed to the Unite Us, which is also now the Unite Ohio platform. And what this does is allows us to work with so many CBOs on an electronic platform so that we can create a more equitable community. Next slide. And so actually, how you can see it, it provides a closed loop communication. So using our electronic health record, and we just went live on Tuesday, by the way. So we're just getting started on this, but it's working. So that's great. Providers and social workers are able to enter a referral, and it goes to any one of our community-based organizations. Currently, we have approximately 70 total that have elected to participate. And then the community-based social service agency can actually return that what they did. You know, did they connect Sue with food? Did they provide housing? Did they move her? And then the provider can see that. And so again, data driving everything that we do. You know, when this becomes scalable, we will actually be able to tie these community-based interventions, social determinant interventions, with clinical outcomes in EPIC, which we are really looking forward to. I'm very happy to partner with Unite Us. Next slide, please. So as we look forward, move next slide. This slide will look familiar to Kimberlydawn because it's the quadruple aim. I think, you know, everything that we're doing as we're collecting data and intervention, everything is really designed across these quadruple aims. And one of my fourth aim is a little different than Kimberlydawn's, but certainly, you know, we want better health population. We want our patients to have a better experience. And if in fact 80% of someone's overall health happens outside genetics and healthcare, to increase their experience, we have to move in upstream and into these social determinants of health. We certainly all want, even if we don't want, we are all going to figure out how to make better value for our money. And then the last quadruple aim that I was talking about is really the better well-being of our team and our providers. You know, what we have seen in big, you know, we're moving to telehealth, change is happening, we shorten clinic appointments, we ask our providers to address all these issues of our patients. If you are a provider and you have a homeless patient, how do you prescribe insulin? If you're a provider and your patient doesn't have a working refrigerator or doesn't have utilities, you can't do the things you need. So our goal in developing these interventions at the Institute for Hope is to make sure that we lessen the burden of our providers and ultimately increase the overall healthcare outcomes for their patients that they're taking care of. So as we work on that, one of the first things we want to do is inform and engage payers. So this exact same information we can now slice by payers, and we can actually work with our payers to work on collaborative initiatives that will help not only their members, but our patients. One of the things we're working on is decreasing capita costs and increased values of care through a collaborative project where we're, as a community, all going to bid on medically tailored meals and see what outcomes that provides. You heard as Food is Medicine clinics from Irene, we're doing much of the same thing with great improvement in clinical outcomes. Through COVID, we've all rapidly learned how to develop new models of care, such as telehealth, home technology, again, allowing everyone to work at the top of their license, looking at community health workers, et cetera. Implement new programs. As I mentioned, we are now implementing Calls for Hope to address social isolation. And we want to expand and make those programs that are working scalable. So we are now working with one of our providers for our Food is Medicine clinic to broaden that. We've had superb results from our school health programs where we've been able to demonstrate absenteeism dropping by 50%, grade point averages going up, compliance with immunizations, all the things that need to happen to make that kid have the best chance of succeeding in life possible. And, you know, we need to be real. And if something is not working, it's okay to say that it's not working. And it's okay to say it failed. And you can either repivot or you can move on and reinvest those dollars. So in addition to informing and engaging in payers, next slide, please, we want to engage employers. Employee turnover is really expensive. Getting good employees is really hard. And these, we actually have started to screen our own employees. It's done anonymously, so we don't have employee-specific results, but we wanted as a system to look at what are our employees, what issues are they facing. And we didn't start until May, so we were right in the middle of COVID, so it is no surprise that stress is off the chart. And it continues to be off the chart, particularly for our frontline caregivers that have kids that are trying to figure out how to get their kids to school. Half of them are taking classes from home, etc. But based on these results, some of the things that we've done is we now as a health system sponsor Health Headspace free for all our employees to help them with their stress. We have committed to a $15 an hour minimum wage. We offer healthy points. We, during COVID and actually before COVID, have really done a lot with employer-sponsored food drives. Obviously, lots of people have helped give meals during COVID. We offer tuition support. We are opening an opportunity center where we can help our employees further their education. We actually have a partnership with Cuyahoga Community College, Tri-C, where our employees can take additional classes with tuition supported. And as I mentioned earlier, we are building affordable housing, safe affordable housing right in our neighborhood. And one of the other initiatives that MetroHealth has taken on with support of a large grant from Dollar Bank is we have committed to provide internet to 1,000 people in our neighborhood. And in our neighborhood, there isn't an AT&T, there isn't a Spectrum. They didn't come to our neighborhood. So we have had a great community partnership to get internet out. The Cleveland school system came in with COVID, and they're helping the kids. So this allows the dollars that we've got to really work on the group that we're calling the strivers. Those are the 18 to 55 or so that are trying to get jobs, need to use the internet for benefits, to apply for jobs. You know, I view the internet like a utility. You know, we need the internet almost as much as we need electricity. And we want to help our providers. As I said, you know, as we look at this and we look by individual site, how can we use the work that we are doing to help our patients be happier, have our providers be happier. And the goal is through the Unitas network and other things that we're doing, that the providers will have to spend less clinical time on social factors and community referrals and more time really addressing the clinical needs. And, you know, this will help us also leverage new models of care so that as we work in teams, multidisciplinary teams, we can all work at the top of our license. And then clearly, everything that all of us have been talking about is, you know, the ultimate goal is to link these social determinant interventions to clinical improvements. And then lastly, you know, how do we engage policymakers? We want to demonstrate the return on investment that is currently going on with decreased tax revenues, increased pressure to cut spending, increased scrutiny of hospital benefit and not-for-profit status. There's a lot coming at hospitals. We need to figure out how to articulate what is working, what is going to add value. And just for your information, there's a couple bills there that we are working on to advocate for. Next slide. And in summary, you've heard it from all three of us, you know, all of this is about really systematically evaluating our impact and being able to do through forums just like this, identify what is working, where do we see financial return on investment, what do we see in terms of improved clinical outcomes, how can we help our community-based organizations collaborate and partner, and how can we use this information for grant and philanthropy purposes so that they understand that the dollars they are investing are really making a difference for everyone in our community. And I think that's it. Thank you very much.
Great, thanks, Sue. And now turning it over to Shira.
Great, thank you. These were such wonderful presentations from all of you on the incredible work that you're all doing. I'm going to kick us off with a question, and then I'm going to try to group together some of the questions that have come in during the past hour so we can get to as many of them as possible. I don't know about all of you. I sort of feel like I end every day needing to find some positive nugget. It's a pretty dark time in the world, and I think it's really helpful to think about what are some positive outcomes, what are some challenges. So I think it would be great to have each of you tell us, just over the past 6 months, you know, what's been a bright spot in your work during COVID? What's your top concern? And maybe what's your most important lesson learned? And I'll just go across how the boxes are appearing on my screen. So Dr. Wisdom, why don't we start with you?
Can you hear me well?
Yes.
Great. I would say a bright spot has been actually leveraging the opportunity around moving quickly in this COVID environment. So as I talked about the Recuperative Housing Center, we were able to get that established and funded very, very quickly. Many of us in this space around wanting to address housing insecurity or homelessness have had challenges in terms of teeing some of these things up. And because of COVID, we leveraged that to actually get the $300,000 grant, to set up 50 beds in a hotel, to offer food, and to get people out of the hospital and into this setting. And now we have neighborhood service organization who's leading it has moved into now a house with 6 that accommodates 6 people, and we'll be able to continue that process long after. Concerns are that this is a narrow window, and that in a year or 2, COVID will be over, and I don't want us to forget what happened and actually lose ground. I'm very concerned that we've already lost a lot of ground in terms of, from a health disparity standpoint, even because many people of all races, ethnicities, diverse perspectives, whether it's LGBTQ community and that sort of thing, have not come in for care. So I'm worried about the undiagnosed cancers, the hypertensions that are out of control, those sorts of things. So I think I'm concerned that we're going to feel another tsunami of disparities as a result of people being afraid to come into healthcare. And thirdly, you said lessons learned, that, move quickly. Don't let a crisis, go to waste. And look for the silver lining in all of this, and make sure that you're thinking long-term, even though this is a short-term problem, that we try to think long-term in terms of the relationships that we're developing, what we're incorporating into practice.
Wonderful. Thank you. Irene, we'll go to you. A bright spot, a top concern, and a lesson learned.
So there's actually several bright spots, but I could start really with the experience that I talked about with our implementation of telehealth. So first of all, it's remarkable that, when things are properly aligned, how the things that you could never move, that took months and months, years to accomplish, like just suddenly materialized. So it actually shows that we have the ability and the know-how. We need to get the right strategies in place. And we actually do really need support, from our payers. And we actually do really need support from our regulators. They're just as much as they could be facilitators, or they could be the barriers to doing the things that we actually need to do. But I was delighted with what we were able to achieve. It actually demonstrated to us that our patients were more than eager to participate in various ways and different ways of communicating and staying in touch with their providers. And this occurred not only for clinic visits, but even I talked about the our health and wellness center. We were due to open in June. Obviously, we didn't because of COVID. But we had all our programs lined up and ready to go. We converted all of them to online opportunities with videos, and our patients, not only did they explain to us how much they wanted to participate in these programs, they really wanted to learn to cook differently, they wanted to move, they really felt very contained and isolated in their homes, and they were very eager to engage in different ways of participating in health and wellness. And seeing both their interest and enthusiasm in participating, and also our ability to provide services in a very different way, delights me and provides me with a lot of enthusiasm as to what we can accomplish in a different way. We really need to think differently. We really do have opportunities here.
Wonderful. And Susan.
I don't think I have a whole lot more to add. Obviously, implementation of telehealth was absolutely fantastic across all 3 systems. We also at MetroHealth started a hospital at home program for people that had COVID or that could be at home. And so that has been fabulous. I just think MetroHealth on March 13th opened up a COVID hotline 24/7. To date, we have received over 40,000 calls. We have connected more than 20,000 people with a telehealth provider visit. And then our care coordinators have followed up with about 13,000 of those. And then Institute for Hope has kicked in, where we have made sure that people have gotten food at home that need to be quarantined, are part of a distribution, a food distribution. received cleaning supplies. And then we've worked really closely with the homeless population community-wide to make sure that there were appropriate supplies at shelters. And though one of the unique things that happened in Cleveland is several hotels that weren't using their rooms for conferences gave rooms for the homeless shelters. And so we had a very community collaboration to make sure that the people in those hotels were safe. So I think those are the things that I can add that might be a little different.
Yeah, those are certainly all extremely inspiring, make me feel better on this, Thursday, 7 months into COVID. We had a few questions about data sharing. Do any of you provide a data platform, or have you created unique data sharing tools to use with all the partners that you referenced? And if so, are there referral loops that are part of those data sharing networks? And how do you track referrals of those patients? So is there anyone that wants to start with that one?
I could say just a, go ahead.
I was just, as I said, we at Metro, and actually we in the Cleveland community had convened all the healthcare systems in the CBOs and the federally qualified healthcare systems. And together we evaluated, and as a community, we selected United. Thus far, MetroHealth is the only one to do that, but that is the platform we are using. It is EHR agnostic, so anybody can participate. And there, I see questions in here about the HIPAA. We did work very closely with our compliance and our attorneys and United, and we consent before it's done. So we have covered the HIPAA issues.
Dr.
At Henry Ford Health System, we're in the process because the closed loop referral is an absolute key piece. And so we have been using a platform. We enter some of the SDOH data in Epic, and we have a Health Leads platform, but the whole community information exchange is what we're learning more about because we actually, for one of our hospitals in the Jackson area, they have a very nice kind of, we call CIE, closed loop referral partners. We're trying to do that. It's much more complex in the Detroit metropolitan area because there are so many other health systems. There are so many partners, and that community engagement is key. So we're in the process of identifying what kind of, and studying that. San Diego also has an excellent one. Even listening to some of you on the phone, on this call, you're even really progressing nicely in that closed loop referral. And that's the key part is, so our community health workers play a key role in entering data, and they're sort of our closed loop referral in an informal way, but we're trying to look how to make that much more systematic, much more that can be replicated across our system. But this has been a journey, and we're continuing to advance on the journey.
Wonderful. Well, unfortunately, I think that we're just about at time, so I'll let Melissa close us out. And just again, want to thank the panelists for a fantastic presentation today.
Yes, thank you so much to our panelists for joining and for presenting and sharing your experiences with us. And thank you to all the participants and for your great questions. I think there are a lot of questions that we probably didn't have a chance to get to today, so I might circle back with our panelists and see if we might be able to get some responses. We can post that online to our website along with the recording.
Sure.
So thank you for everyone for joining. Let us know if you have any questions about Aligning for Health, about the American Hospital Association, or for any of the panelists in particular. We're also happy to do connections. So thank you, and have a great rest of your Thursday.
Thank you.
Take care.
Take care. Bye-bye.